Thank you for choosing Lyerly Neurosurgery at Baptist Health. Our goal is to help you lead a fuller life free of symptoms caused by spinal issues. Although no procedure can be guaranteed 100% effective, we have helped countless patients alleviate chronic pain and other effects of spinal issues.
So obviously this is a model of your cervical spine, and just to get everybody oriented, this is looking directly at the front. Obviously you can't feel or see any of that. When you feel your neck, what you're feeling is your trachea. Behind your trachea is your esophagus or your food tube, and then this is the front of the cervical spine. So if we kind of turn it around to the side, you can see this would be the back of your head. When you feel that kind of knot at the base of your neck, what you're feeling is you're feeling the spinous process of the seventh neck bone. So now that you're oriented, basically the spine ends up being fairly simple. It's just repeating units. So you have vertebral body or bone, and then you have disc and bone, and it just repeats itself. The way that we name the different parts of the spine, if you look at this disc right here, it's in between the seventh cervical neck bone, or C7, and then the C6 bone is up here. So the disc in between the C6 and the C7 bones is simply called the C6-7 disc. So 6-7, 5-6, 4-5, and so on. So don't let the two numbers confuse you. When we talk about a C6-7 disc, we're talking about one disc in between two bones. Basically, you have two different conduits or passageways through which neural structures can pass. The big one is the canal, which is the conduit through which the spinal cord runs. And then you also have these side holes called foramina that are the passageways through which the nerves exit. And a number of these nerves will end up becoming the nerves that go to your arms. Each nerve has a specific distribution. And so if you end up, for example, with a problem at C5-6, and you ended up with nerve impingement on the nerve exiting through the side hole at C5-6, that nerve is referred to as the C6 nerve. And each nerve has a fairly specific distribution that it runs. So what you can have is with C6, for example, you can have pain that classically would go over the biceps into this portion of the forearm called the radial forearm, and then into the thumb is kind of a classic C6. And each nerve has a specific distribution just like that. You also have these joints on the back side of the spine called the facet joints. So really, when we're talking about each segment, for example, again, C6-7, we're referring to a complex of three joints. The disc itself, which is the C6-7 disc, and then you have these paired joints called facet joints on the back side. So when we talk about different ways in which folks can have pain related to their cervical spine, there's two major categories in which you can have pain. One is that you can actually have pain that can arise from arthritic or inflammatory processes involving the joints themselves. The actual term arthritis is referring to that. So arth is joint, itis is inflammation. And when we look at the cervical spine, there are three potential joints that can be inflamed at each segment. One is the disc. You can have what's referred to as discogenic pain, and then you can also have pain that arises from these facet joints, which are the paired joints on the backside. Folks who are symptomatic from discogenic or facetogenic pain typically will complain of pain in the actual neck itself. It's very, very common for us to have folks complain about pain in the trapezius muscles, in the shoulder blades, in between the shoulder blades that we've referred to as interscapular pain. And it's not uncommon that we would have folks complain about pain in the back of the head that could be perceived as a headache. So all of those symptoms are what we refer to as axial or midline symptoms, and they're commonly associated with folks who have pain emanating from the actual arthritic joints. That's very different than folks who have symptoms or pathology that is attributable to what we would call neural compression. Okay, so when we look at these nerves coming through the side hole, if you either have disc material that's pushing up against the nerve root, or you have stenosis, which just refers to narrowing of a passageway through which a nerve would pass, you can end up with symptoms attributable to that neural structure. So very commonly somebody would come in with a cervical disc problem and complain of not just neck pain but also neck and arm pain. And the pain that can radiate down the arm in someone who has significant nerve compression, typically that nerve has a very specific pathway that it takes. So for example, if we look at this very bottom disc, which we would call the C6-7 disc because it's between the C6 bone and the C7 bone, compression of that C7 nerve would cause pain that could involve the triceps, the back of the forearm, and it can go into the index and the middle finger in a patient. The second way that it can compress neural structures is some of the disc material pushing back up against the spinal cord. So it can push up against the nerve, which would just cause the arm pain, or you can have it push up against the spinal cord. When it pushes against the spinal cord, it can create something that we call myelopathy. And when we refer to myelopathy, we're simply referring to symptoms and signs associated with malfunctioning of the spinal cord. Some specific examples would be folks who have some loss of fine motor control. They may develop urinary urgency or frequency or even incontinence. They can have spasticity or stiffness in their legs and even some balance related issues. And again, that's referring to folks who have significant spinal cord compression, whereas folks who have nerve compression, which we call radiculopathy, their biggest complaint is going to be one of pain and typically involving the arm itself. So those are some of the more common ways that cervical pathology can manifest. Now I'm going to talk a little bit about surgical treatment of cervical or neck pathology. The most common type of surgery that we would do for someone with cervical spine pathology is an operation in which we would go through the front of the neck. And some examples of common pathologies that we would treat with this would be folks who had nerve impingement creating neck and arm pain, or folks who had pressure that was on the spinal cord creating what we call myelopathy or spinal cord malfunctioning. The reason that we go through the front of the neck, it's a little counterintuitive to a lot of folks, but there are two reasons that we like to go through the front of the neck. The first reason, so if you look at this model, on the top you have this column of disc and bone, in the middle you have the actual spinal cord itself, and then here's the back of your neck right here with all this muscle, and this is what you feel when you push on the back of your neck and you feel the hard part. So most of the pathology is really centered around disc pushing from front to back. So if we were to go through the back of somebody's neck, number one, we're going through a lot of muscle, which hurts, but number two, we're looking at the back of the spinal cord when the disc, in fact, is pushing from front to back, so we're really on the wrong side of the pathology. So we typically will go through the front of the neck. When we go through the front of the neck, we make an incision. It's usually on the right side, not always, but it's a horizontal incision. It's an incision that's probably about this big. We try and make it in a crease in someone's neck. And when we do that surgery, our trip from the skin surface down to the front of the actual bony spine itself is done largely without having to cut any underlying structures. There's very minimal dissection. A lot of it really is related to just moving things over to expose the front of the bony spine, and because of that, the patients rarely have a lot of front of the neck pain or incisional pain per se, and we'll talk about that a little bit more. When we actually get this exposed and we're looking at the front of the spine, the problem is that we're looking at the front of the disc, and the pathology is not on the front of the disc, it's the back of that disc that's pushing up it either against the spinal cord or up against the nerves that are coming through these side holes. And so when we do this surgery, we're removing or excising that disc in its entirety to get to the back of the disc that's abutting or pushing on that neural structure, and then we're elevating that material away. So the primary focus for most folks would be to get to the back of that disc to decompress or take the pressure off of either the nerve or the spinal cord or both in some patients. Once we have achieved that goal, once we've gone in and we've removed all the compression, we cannot leave that as a blank space. And so what we typically will put in its place is a spacer. It's a plastic, medical grade plastic spacer known as PEEK, which stands for polyether ether ketone. Basically, it's just a medical sterile piece of plastic, and it's a ring. Within that ring, we place a material that is somewhat analogous to kind of a crushed coral material that allows bony bridging or fusion across that space. Just like a person who has, say, a fracture of their forearm, and you want those two bone ends to mend or heal over time, and you require a cast, we also need some sort of stabilizing device to hold things in position until that bone bridges or grows over time. And so what we typically will use is a plate. The plate goes onto the front of the spine and sits flush, and you can see from a side view it's a very thin plate. If you look closely, you can see that there are these spacers in between the levels. So what you're seeing here is someone who has had a 2-level cervical fusion with this anterior or front of the spine cervical plate. That surgery that I'm describing to you, for a 1 or 2 disc operation, we typically do it as an outpatient surgery. If we do a 3 or more disc operation, it is typically a 1-night stay in the hospital. In terms of the surgery itself, for a 1-disc operation, it typically is about a 45-minute procedure. For a 3-disc operation, on average, it's about a 2-hour procedure. In terms of benefits of doing that surgery, the benefits really are the reduction in pain, either in neck pain or in nerve pain or spinal cord compression symptoms attributable to that specific level. So if somebody comes in and they have neck and arm pain, and we go after this disc, which we believe, based on the imaging and the clinical presentation, is the primary source of the patient's pain in both their neck and arm, whatever pain really was attributable to that is what we're going to alleviate. So for example, if I went in and I did an operation here at C6-7 because somebody had symptomatic right arm pain from compression of this right C7 nerve, I'm most confident in that scenario that I would alleviate their arm pain. Neck pain that came on with the arm pain, there's a reasonable chance that I would improve that neck pain, but I am not as confident when I do this surgery that I can alleviate all of somebody's neck pain. Not as confident anyways as I am about the nerve pain portion of it. And the reason being, if I see that only this nerve is compressed and the distribution of the patient's arm pain is attributable to or conforms with that specific nerve distribution, I have a high degree of confidence that I'm going to alleviate that problem. But there could be degenerative changes that aren't warranted for surgery. They're not bad enough, but they could contribute to some degree of neck pain. So in terms of benefit, for somebody with neck and arm pain, we're more confident that we would alleviate arm pain. There's a chance that we could help with neck pain, but we cannot say it with the same degree of confidence. In terms of risk of this surgery, the risk of infection is 1% or less. It's quite rare to have an infection associated with this procedure. Blood loss during the surgery is minimal. I would say that we're in the teaspoon range from doing this type of surgery of actual intraoperative blood loss. I personally have never given anybody a blood transfusion for this type of problem. The risk of injuring any of the structures around where we're working, so spinal cords immediately adjacent, there are a number of big vascular structures, trachea, esophagus. Creating any sort of catastrophic insult or injury to any of those structures cannot be impossible, but it's way under 1%. It just cannot be 0%, but it's extremely unlikely. The two things that we worry the most about when we do this surgery are swallowing problems and hoarseness. And when folks have swallowing problems or hoarseness, it's not an oops, we accidentally cut or bumped into something, it's a retraction phenomenon. So when we do the surgery, we are retracting against the trachea and esophagus this way, and then the carotid artery is retracted on the other direction to create a corridor in which we do the surgery. When we do that retraction, there is a nerve called the recurrent laryngeal nerve, which is a nerve to your voice box that we can make sleepy. So it's not a cutting of that nerve, it's a stretching of that nerve, and you can end up with a palsy, and it doesn't send the signal to the vocal cord on that side. And if the vocal cords don't oppose each other, you can end up with a little slackness in the vocal cord on one side, and some air can get out, and you can end up with a raspiness in your voice. Same sort of deal with the esophagus. People can have swallowing problems because we're retracting on the esophagus. Most of the folks that would have a problem with swallowing or hoarseness, they would be relatively mild and short-lived, but there is a risk that a small number of folks could have more significant swallowing problems or longer-lasting hoarseness. Most of them would describe something along the lines of for a couple of weeks after the surgery, I had to chew my food a little bit better if I ate something difficult to swallow like a piece of steak, but then it resolved. Or maybe they describe a raspiness in their voice, or maybe the volume of their voice in a crowded room was somewhat diminished, but again, we would expect those things to resolve. The likelihood of developing a significant problem with swallowing or hoarseness is strongly correlated with how many discs we're operating on. So if we just do a one disc surgery, it's quite rare that we would have a significant swallowing problem or hoarseness. Similar with 2, 3, we occasionally see it. When we do a 4-disc surgery through the front of the neck, we really start getting nervous that that's a potential risk for that patient. And the reason that is it's a retraction phenomenon. So if we retract for a short period of time over just a short segment for a 1-disc surgery, the likelihood is a lot lower than if we retract for a longer period of time over a longer segment. So the more disc that we're operating on, the greater the risk of having swallowing problems or hoarseness. And that's an important factor when we counsel folks on these surgeries. Most of the folks in terms of recovery who have this surgery, like I said, if it's a 3-disc or a 4-disc surgery, would typically leave on post-op day 1. I would say 95+% of the folks who have a 1 or 2-disc surgery will go home the same day because they're up and around. People complain about 2 things after the surgery. They complain about a sore throat, which typically is diminished within a couple of days. And then the second part is fairly variable. It's back of the neck, trapezius muscles, and in between the shoulder blades. And it can be on this end of the spectrum where it's simply kind of a mild stiffness, or it can be an actual spasm that hurts. And it is very difficult to predict where folks will land on that spectrum. I would say that the fact that for a 1 or 2-disc surgery, 95% of the folks go home the same day. It's a pretty good testament as to what kind of pain we expect folks to have. Not that many folks would be going home if it was really painful, but in terms of return to work, that's where it gets a little bit difficult to predict. I would say that typical return to works could range anywhere from 1 to 4 weeks. We typically say, recommend telling your employer that you'd be off for 2 to 4 weeks. If you're on just the mild end of the spectrum and just have a little stiffness, it's not impossible that you could go back to work, a week after the procedure. But if you're having spasm and discomfort, then it could be a month out of work. So we have some variation in that, and again, it's not how the surgery goes. It's a lot of the pre-existing inflammation within those discs, and that's where those back of the neck symptoms and in between the shoulder blade that I'm describing comes from. It's not that we did surgery in the back of the neck. It's a referred pain from us manipulating an already inflamed disc or joint. Even the folks who have just a mild degree of stiffness and are able to go back to work sooner than later, we still say we do not want them to do a lot of lifting or bending. We typically limit it to 10 pounds. We don't want a lot of repetitive or stressful things that involve the neck for about a month after the procedure, and that's something that we would counsel them on based on intraoperative findings, and we see everybody back at a 2-week follow-up visit. But typically it's about a month, sometimes a 6-week restriction on post-operative activities. So that is a description of what we call an anterior cervical discectomy infusion using an anterior cervical plate.
Our goal is to help you live a pain-free and fuller life. If you have any questions, our staff is here for you. We will be with you every step of the way. Thank you for allowing us to care for you.